Welcome back to 10 Clinical Minutes. Today we're going to be talking about GI bleeds, and this will be part one of a multi-part GI bleed series. So we're going to be talking about today the classification and initial evaluations of patients who come in with the chief complaint of a GI bleed. In later series, we'll talk more about management, stratification, triaging, and then some underlying etiologies of lots of different kinds of GI bleeds. So we'll talk about definitions, some manifestations, how to differentiate different types, and then the important parts of the H&P that you need for the chief presentation of a GI bleed. So the main anatomical classification that's used is the upper versus a lower GI bleed. And that's based on being above or proximal or distal or below the ligament of Treitz, which is used as an anatomical landmark to distinguish between the two. It's important to know upper versus lower because they have different etiologies, and the underlying anatomical classification helps direct your initial steps in management. And then also knowing the etiologies helps you distinguish severities and how you triage these patients and what endoscopic evaluations you do first, second, and also gives you an idea of what to expect from this patient. So additional classification, overt versus occult versus obscure. This is a thing that oftentimes attendings will nitpick you on because they're very important to know the difference between the two, but aren't commonly compared. So overt is something that when you think about the classic GI bleed, so if you have blood coming out of the anus in stool or through vomitus, you can see it frankly, that's an overt bleed. An occult bleed is a microscopic bleed. So it's one that a patient won't report, I have blood in my stool, but there will be signs and symptoms of blood loss from somewhere, and then it will be seen on an evaluation when looking for an underlying cause for iron deficiency anemia, or they've had a positive fecal occult blood test. That won't really be like an acute bleed presentation, but it's something that could be found in a workup for anemia. And then an obscure GI bleed is similar to an overt bleed, but you can't find the source. So it's like a technical definition for a GI bleed that is known, but on endoscopic evaluation, you do not see it on upper or lower, but they're continuing to have signs and symptoms of melena or hematochezia, and additional steps need to be taken in order to find the underlying source. So there's a few manifestations that you can look for when you say this patient is having a GI bleed. Those primarily are hematemesis, coffee ground emesis, melena, and hematochezia. Those four terms are the main ones when we think of overt GI bleeds. I also put on there bright red blood per rectum because it's an additional term that's used, but it kind of is a separate kind of GI bleed. So hematemesis is blood seen in the vomitus. So your patient will say, I threw up and there was frank blood in it. You can compare that to coffee ground emesis, which is another form of blood in the vomit, but it shows up as dark black spicules or dark brown spicules in the vomit. And that's just from oxidated blood. Talk a little bit more about that later on. And then melena, hematochezia are the two things that you'll see a lot, and you'll see patients will know kind of one of those terms, and so they might use it, but they're very specific clinical terms that you really should know the description for each one because it's important. It has important clinical implications. So melena is a black, tarry, shiny, foul-smelling stool. So if you see melena for the first time, you will never forget it, and I guarantee you will not ever forget the smell as well. It really does look like tar, and really one of the big things that you will hear from patients is that it's really hard to wipe because it has that consistency. And so if someone says, I have really dark stools, then you ask them, are those like sticky? Are they hard to wipe? And they say no. That might raise a red flag saying maybe that's not melena. It doesn't mean it isn't entirely, but it just means, have your feelers out there to think maybe there's something else going on that's mimicking that. And then hematochezia is when there's bloody or maroon colored stool with clots often found within the stool. This is when blood is really in the stool sample that you have. So it's not kind of on the outside in the bowl, anything like that. There is blood mixed in, meaning that there is an opportunity for blood to intermingle with the stool formation, indicating that there's a bleed happening somewhere along the GI tract when it's coming out. So you can compare that to bright red blood per rectum. And so that's something that more is used for very small amounts of blood that's oftentimes seen with anal pathologies. And so that's when people say, I wiped twice and then I looked at the toilet paper and there was blood, or there was a tiny bit of blood, a couple of drops of blood in the bowl, or a little bit of blood around the outside surface that kind of looks like it's coating the stool. But if you look close, it's not really a part of the stool. And that's some of those classic anal pathologies like hemorrhoids, things like that. It doesn't mean that it can't be clinically significant, but that is less likely something that we think of when we think of like the big significant GI bleeds that people are hospitalized for. One of the main ways that we differentiate between upper and lower bleeds initially or doing any other endoscopic evaluations is by those clinical manifestations we just talked about. So hematemesis and coffee ground emesis are indicative of something happening either in the stomach or the esophagus. And the difference between those is that coffee ground suggests, generally speaking, that there is more time for the blood to be sitting in the gastric acid to oxidize. And so that means it's usually a slower bleed or maybe a less clinically significant bleed. Something to evaluate, it's still something to look at, but it doesn't mean that there's currently an active bleed going on. Melena is usually indicative of some sort of upper GI source. So the more proximal a bleed is, the more likely there is to be a sign of melena. So that black pigmentation comes from the oxidation of heme to hematin, and that requires a lot of time within the GI tract. And also it's most effectively done when it's exposed to gastric acid. And so that's why you'll see like peptic ulcers, those kinds of bleeds, those are the classic melena picture. But there's also a small amount of oxidation that goes on via the bacteria that's in the small bowel and colon as well. So it is possible that there is some small amount of melena that could be happening due to other sources of bleeds. But generally speaking, if you think melena, you think of something stomach, duodenum, esophagus. And then hematochezia can be upper, but generally is considered to be a lower GI symptom. So because blood has to have time to oxidize, if it's happening somewhere, especially in the descending colon area, like a diverticular disease, there isn't time for that blood to be oxidized, and so it'll come out as bright red blood. It is possible that if you have a rapid enough upper GI bleed source that is hemorrhaging, essentially, that there's enough blood that can pass through that won't be oxidized all the way, so you will see a hematochezia type picture in an upper GI bleed. But you'll have other reasons to believe that there's something else going on if you see that, and that'll be in your vitals and in your lab findings, which we'll talk about in a later podcast mainly. Like I mentioned earlier, bright red blood per rectum is mostly significant for anal pathology. And then there's some other signs and symptoms that you can point to upper and lower. And we'll talk about more about that when we get to labs and evaluation more later on. But generally speaking, we have a chief complaint of a melena or hematochezia that should make you start thinking about, this is what I'm expecting and should be looking for in my physical exam, my history finding, because that can help you kind of start thinking about the right clinical picture. So the big questions you need to be asking when you see a patient who comes in is, first and foremost, has this ever happened before? Have they ever had a history of GI bleeds? Because if it's someone who's come in 8 times, all for AV malformation, and they've had 20 bleeds, it makes it a lot different than someone who's coming in for the first time. It's also important to ask if they've had any previous endoscopic evaluations. I would say one of the most important things to do is to describe those endoscopic evaluations. Don't just ask, have you had a colonoscopy? Have you had an EGD? Ask them, have you had a camera placed inside of you to look up your colon or down your throat? It's also important to know like the date and the time of the bleeds. Has it been happening a long time? Did it happen once a week ago? And it's really important to know their medication history. Think about the conditions and comorbidities that they have, because those comorbidities not only will affect their management, but also knowing what medications are associated with what conditions. But it's really important to make sure they haven't had liver injury and any surgeries in the past, especially aortic stents, because we're worried about aortoenteric fistulas. And any cancers can cause, obviously colon cancer, but we're also concerned about previous radiation that can cause bleeding. And really the things that you need to be thinking about for your physical exam is the general abdominal exam. So you're looking for scars, seeing if there's any surgeries that they didn't tell you about that you see, looking for anything that can localize a potential source. If you have left lower abdominal pain, you're thinking diverticulitis kind of picture, or if you feel a huge mass or you feel hepatomegaly, look for any signs of any liver disease, because then you're thinking the whole variceal or gastric ectasia type picture. And then also there's underlying question mark. Do we need to do a DRE? Do we need to do an endoscopy? Some people will say absolutely yes, but some people would say no. It's kind of up in the air. But if you think about, if you don't really know, is this melena, is this hematochezia, you can do an anal exam and say, yep, this is black, this is tarry. or this is bright red blood. You can, at the same time, if you feel hemorrhoids and you were thinking hemorrhoids, and you can do an anoscopy to look and evaluate for any anal pathology, that might be the underlying cause. It might not mean that you don't do any other additional evaluations, but it can give you an idea of what might be going on and rule out something and add something to the differential. And then it also gives you an opportunity to look at the poop. And if you have an actual stool sample, make sure you ask your nursing staff. They'll tell you if they smell melena, that's for sure. One thing to note for the vitals, and we'll talk more about severity in the next podcast, but if we're thinking about hypovolemic shock, and that's the thing we're worried about, sometimes patients will be on beta blockers, and that can hide early tachycardia, which is actually the first sign of hypovolemia in these patients. So have that on your radar when you're evaluating these patients. So if you're thinking, I'm concerned about this, and you see a beta blocker, maybe it's actually something higher than that. We're just not seeing it. So I'll just kind of run through some of these pearls. I won't go through them, but they're really good to take a peek at. And these are some of the things that some of the GI attendings that I've talked to over the years have noted as we have gone around on rounds. All right. So that does it for today. We'll talk more about severity and management and etiologies in a future podcast as well.